Advantages of the dose and cost therapy. I have a slogan that I used to say, everybody deserves a trial. So even the most unusual situation, when you get into a corner with patient, you feel, well, I'm not sure it's going to work, the trial is one of the safest things I ever do as a pain specialist. I can tell you, in my opinion, I feel safe doing a dorsal column stimulator trial than doing epidural. When I do an epidural, I'm injecting medications, I'm injecting local anesthetics, I'm injecting steroids, and that patient can have reaction to those. I do a trial, I just put a lead in, it's so safe, it's so secure, it only works or it doesn't. I can see a patient getting any complications for what I do. Infection is a possibility, but I can tell you very remote possibility. I probably have done thousands of trials throughout my career. I have zero infection, even slightly remote possibility of infection throughout trials, and I never heard about it. So talking to my colleagues, I haven't heard about anybody who had infection throughout trials. Implantation is a little bit different because it really involves more of the cuttings and techniques that a lot of people don't have it. So that is a little bit more greater, but I also don't have any infection. This is a clean procedure. It shouldn't have high-risk infection at all. I have done in patients with immunity compromise, HIV patients, I have done cancer patients, and I had had a chance to really face dorsal column stimulator infection. It's possible with the implant. I have heard about it. With the trial, I never even heard about it. So that's how safe the trial is. It's something testable. So that's what I say. I can do an epidural, but I don't know how the results are going to be. This is something that I know I only going to implant a patient that it works. So it's something very good. You know, I'm saying, like, you know, we're only going to marry somebody that's going to work. It will be, everybody's going to be happy. So this is something testable. You can test. So what the patient lose? Very few things, you know, very little. There's not much involved in the dorsal column stimulator trial when you put in comparison what the patient is going through in terms of suffering. So in the beginning, as a physician, all of us has a little bit of hesitance to do things that are invasive. But how much more invasive can be when the patient is taking 18 pills a day, or sometimes 18 pills at once to get the pain control? How much side effects that patient gets every day? How much more problems they are prone to face? So we do one problem, we do one test, we do one implant, and that's it. So a patient can have good many years of pain relief based on one procedure that you do once. So I start to lose this fear of implantation after I see the results. The happiness on the patient faces that you guys see it. You know, like they're coming in, this is wonderful, this is very good, and I become the best doctor in the world because I'm providing them with a great relief. And non-destructive. As I said, we don't change anatomy. It's not like when you're doing a spinal surgery, they're going to do laminectomies, they're going to put fusions in there. You don't do anything. Even if it doesn't work for any reason, you go there, move your leads out, that's it. Patient's normally back to the original stage. Reversible. Even if we implant somebody that it thought they were going to work, and sometimes you just go there and take it out. It takes 15 minutes to take this out. And long-term cost is low. So there is a lot of studies in that how we could get most of the insurance to pay for that is really showing that the patients, the cost is really much low. And it really is. If you guys look at how many times you see a patient with meds, how much they spend in meds, how much involved in terms of, you see my dorsal column stimulator patients, I forget about them. I put the stimulator and I see them for the first 2 or 3 months, and then I forget about it. They're gone. Even if they take some medications, they come every 3 months, take off a prescription, because they are much better, they're much more stable. Even going to the pump patients, the same thing. I see them for refills and that's it. So in my refills cost $150 when most of the medications cost $500, $600, $700 in a month. So there is a real long-term cost effectiveness in here. And we're talking about everybody, nurses' involvement, office involvement, pharmacy involvement. It's really a much lower cost overall. And also give time to those patients to get involved in the economy, to work, to do some activity, when most of our pain patients is so involved in their own illness that they have no time to do anything else, even think about rehabilitation itself. Okay, disadvantage, like nothing can be perfect, and limit to very specific indications and disease. There are a lot of diseases that we can do it. A patient with severe osteoarthritis involving multiple joints, you're not going to work with that. Some patients do not respond to it. Very few patients, I can tell you. When I have a good indication, a good etiology, I only feel very few situations when the stimulator did not work. Most of the time, when the patient is very well prepared, when the patient really wants this, it's not really a drug issue, anything like that, when the indication is good, I can tell you it works. It's amazing. It's really amazing. Short-term cost is high, so it makes it very difficult for a lot of insurance and hospitals and patients are really going to pay out of their pocket. It's very difficult. Needs follow-up. I really don't look at that. It's really very minimal, my follow-up with stimulators. When you do good lead implantation that they don't move, it usually doesn't require that much follow-up. And the steep learning curve, yeah, that's it. We're still learning a lot. I think we're really much far ahead now. And the more experienced you are, the better results you're going to get by preparing your patients. So that's how we do the implantation percutaneously. We put the 2OE needle in the back like we do in epidural. That's why it's such a simple procedure. It doesn't involve much more than that. Then when my needle gets in the epidural space with the fluoroscopy and lots of resistance, I introduce a guide wire. Here comes for you guys for the technical aspect of the procedure. Yesterday I was one of the fellow, and I want you guys to understand. This is a 14-gauge needle. When you are going to the epidural space, make sure you use all the tools you have to confirm your placement. Meaning, okay, it seems that my loss is not good. You don't care. If you don't have a full resistance, you have to make sure that you're not there yet. Use everything you can use. Use your guide wire. Use your fluoroscopy. Make sure your depth is good. Because if you get with this 14-gauge needle in the interthecal space, is a lot of fluid come out. This patient could have a lot of severe headaches. And even if you place your lead there, you might have a lot of other factors, the variables that are going to be impact on the patient response throughout your trial. So you don't want to have that. And I can tell you, I remember once the patient had problems with had a laminectomy before with scar tissue. It's very unusual to have a wet taps with stimulators, because the needle really, you can really feel where you're going. You really can confirm. You know, just put your lead in. If you're not in, you're not in. So your lead doesn't go in your epidural space. It doesn't go in epidural space. So just don't move on. Oh my, I think I have it. No, you have to have a good resistance. You do put your lateral view, look where you are, put your lead in, see the lead goes. So that's the easy way to confirm, right? Just to know where you are. Give your contrast. Do whatever you have to do to make sure you're there. Okay? Introduce the guide wire. It said insert the lead and confirm lead location with the fluoroscopy. That's how we do there. This is a tunneling. I almost never do. Almost nobody does in the front. And I did it once this week. I don't know who was with me, because the patient requests. The patient specifically requests, I don't want it in my back, I want it in my front, so I did it in my front. So, but most of the time we do in the pocket, creating the gluteus area, and we create a package, you identify the areas you want to make sure C is really in the middle, make sure you're far away if you do in the front, far away from the ribs, far away from the bony area, and you can put it here. I like to sometimes put a little bit more in here. I think it's flatter and patients see less just for aesthetic reasons. Otherwise, it can be anywhere. Then you tunnel after your creation and you connect.